Hi, and welcome to Attentive Healthcare Solutions webinar, Everything You Need to Know for MIPS Audit Using NextGen. My name is Chelsea Grover, and I'm the Marketing Communications Manager for Attentive. Before we get started on today's webinar, I want to take a moment to explain the process for the presentation. First, I'd like to mention that this webinar will be recorded, and that we'll send out a copy of the slides along with the recording within the next week. Next, I have some super exciting news to share with you all. Attentive is now part of DAS Health. DAS Health is a leading provider of health IT and management solutions and a trusted consultant to many physicians groups, hospitals, and healthcare systems across North America. By combining our skills and expertise, we'll be able to provide even more support, value, and solutions to your practice. We're looking forward to continuing to serve you. Again, I want to reassure you that we're still here for you. We're still going to be here specializing in next-gen healthcare and keeping our focus on you. We're still going to be passionate about providing solutions for healthcare provider partners, which in turn help them to improve patient care, enhance the patient experience, and maintain a financially healthy practice. We're also going to continue to do everything NextGen and have NextGen add-on productivity solutions, including ChartGuard, Refund Manager, Unapplied Deposit Manager, and Multiple Encounter Billing Manager. So it's almost the new year, so happy holidays, and I hope that you will join us next year as we start our new series of educational webinars. We have a bunch of exciting topics planned, so make sure to keep your eyes out for invitations to those. Okay, so back to today's webinar on everything you need to know for MIPS audit using NextGen. At the end of the presentation, we'll open the floor up to questions from you. We'll answer all the questions at the end, but you can type them in the questions area of the webinar control panel whenever they occur to you. And finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please use the chat box to let us know so we can resolve them. And again, questions may be entered in the questions box. So without further delay, I'd like to introduce our presenters for today. Lindsay Lanning is Manager of Client Development, and Holland Lively is a consultant at Attentive Healthcare. They're both super eager to share their knowledge with you. So with that, I'm going to let them get started. And don't worry, Lindsay's a lot more eloquent than me at speaking. So Lindsay, it's all yours. Feel free to get started when you're ready.
Great. Thank you, Chelsea. I don't know about that. I am fighting a little bit of a cold here, everyone, so I apologize if I could do a few throat clearing here and there. But besides that, hi, everyone. And again, thank you for joining us on our topic today, everything you need to know for a MIPS audit using NextGen. This topic was actually brought to us by one of you. So shout out to you, Diane, if you're on today. She was actually able to comment on our LinkedIn post requesting this topic. So keep that in mind, spread the word if there is any specific topic you would like covered, whether it be regulatory, just healthcare industry related, or NextGen specific. Don't be afraid to reach out or engage with us. Our contact information will be here at the end of the slide, as well as, of course, on LinkedIn with our weekly post. Now back to today. Last August, CMS actually announced that it would be resuming previously suspended medical reviews, as well as initiating new audits, regardless of the status of the current public health emergency. This surprised a lot of people, and it put some into panic mode trying to prepare, and we wanted to provide an overview of the audit process so you knew exactly what to expect and go into a real deep dive of everything we recommend putting in your audit binder for each year. So that's going to be the majority of the presentation. Time permitting, we will provide a very high-level overview of the changes you should be aware of for MIPS reporting in 2022. I am talking one slide of information. I just know the crowd on this webinar are the ones who likely handle MIPS for your practice, and there are some key changes you should be aware of before January 1st, if possible. So our goal is to make sure you leave this presentation knowing how to survive, or scratch that, thrive in a MIPS audit using NextGen EHR. So warning, this presentation may contain overwhelming and somewhat frightening material, and this may lead to increased stress levels, especially around the holidays. So now, and I know we did this as sort of a whimsical way to introduce this topic, but it's true. Audit is not a pleasant word for anyone to hear. The fear of being caught, for some little mistake or a missing checkbox can strike fear into even the bravest of documentation experts. And for providers who are submitting under MIPS especially, there's thousands of dollars on the line, and that can be overwhelming and somewhat frightening. But that's why we're here today, to share with you exactly what to save in order to avoid failing an audit. Because I'll be honest, failing an audit, whether it be one of the old meaningful use ones, a HIPAA one, or even a MIPS one, is actually much more common than you would think. So before we get started on how to prepare, I want to ask all of you a few questions to evaluate how ready you are right now for a MIPS audit. So number one, simple. Did you submit data onto the MIPS program anytime from 2017 to 2020? If you answered yes to that one, do you have a complete binder or saved folder of MIPS attestation data for each year? And have you already started one for this year? And then the last question, if you received an audit letter today, could you have all the information CMS requested within 45 days? So again, these questions weren't meant to send anyone over the edge. It was to bring attention to the fact that a lot goes into preparing for an audit and it can be intimidating, but it's possible if you just understand the process, anticipate what CMS is likely, or Guidehouse or contractor will likely be expecting of you. And the key to it all is really staying organized. So what if you are selected? And let me probably rephrase that, since it really isn't a matter of if, but when you're selected for an audit, it's crucial that you're prepared. Again, not a matter of if, but when. When is the CMS, formally going to announce that they would review and audit the MIPS program? We also wondered if they use the same contractor who previously audited the old meaningful use program. Would they hire a different contractor? We had a lot of questions and we were kind of waiting for the other foot to drop. We now know MIPS data validation and audits, DVAs, will be performed on a select number of eligible clinicians, and it has begun in 2019 already on the 2017 and 2018 performance years. And according to CMS, Guidehouse, who's the contractor, who's tasked with conducting these DVAs, are said to be, looking at these processes here that will help ensure MIPS is operating, with accurate and useful data. They're auditing the program for that reason. And it's important CMS put in their announcement right there in bold, MIPS eligible clinicians, groups, and virtual groups are required by regulation to comply with data sharing request, providing all data as requested by CMS. Now, with little surprise, after this initiative was announced, COVID hit. And on March 30th, 2019, CMS actually suspended any Medicare fee-for-service reviews, which included those MIPS data validation audits. So, and then again, that's what you're seeing on the left side of your screen for July 2020. Then you can see again in that FAQ, CMS came back and said it was going to resume these audits as of August 3rd, 2020, and they would continue with new audits regardless of the current public health emergency. Well, they must have resumed those audits and really not like what they saw, because only 2 months later, CMS came out with the announcement on the right, basically stating if you were selected for a MIPS audit, or what they were calling that DVA, which again, that stands for data validation and audits, for 2017 or 2018, it was purely educational and no actions are going to be taken. No money is going to be recouped if you failed. You still can get your feedback on your audit, but essentially, again, there's no money on the line. They're not taking any of the incentive payments back. Now, this does not mean audits are over. CMS has come out and said it is going to conduct these DVAs annually to ensure the program, again, operates with that accurate and useful data. And because MIPS audits are required by law, if you're selected, you're going to have to comply with all those data sharing requests. If anything, they will likely come back starting with 2017 and onward again, and we expect they could announce another wave of DVAs at any time. Again, there's a lot of money on the line being distributed with this program, which is why the audit process is in place, and they can take that money back if you can't pass the audit. So we know why they're doing it, but how do they go about choosing who's going to be subject to one? What specifically causes a MIPS audit? Well, these can be, one, random. You can be selected out of a random pool of providers for an audit. CMS even stated MIPS participants will be selected randomly for DVAs. However, there has to be some judgment included, and they're going to do that in that sample selection to enable them to include a variety of clinician types. So they wanted to include urban, rural providers, large groups, small groups, and they also wanted different submission methods audited as well. Whether you did submission through your EHR, through a registry, through claims, the QCDR, or even the web interface. Now, there are also targeted audits, and there are numerous reasons on how this could be a targeted audit. And some of those reasons include failing a previous audit, whether it be an old meaningful use one, a HIPAA one, or maybe even one of those 2017, 2018 DVAs that they didn't actually take action on. Now, the failure of a HIPAA audit may surprise some of you, since HIPAA audits and MIPS audits are supposed to be completely separate and independent of each other, right? Well, wrong. We've learned that even though the OCR is the enforcing arm of HIPAA, and CMS or Guidehouse is the enforcing arm of MIPS, they can report failed audits to each other. It's up to their discretion. And one very key element that overlaps between MIPS and HIPAA is the security risk analysis. So if you fail a HIPAA audit, there's a good chance OCR could reach out to CMS or Guidehouse and say, hey, X provider failed a HIPAA audit, which is a pretty good indicator that provider may not be in compliance with MIPS under that PI category either. Check them out. Along the same lines, a failure of a previous, meaningful use or MIPS audit. Some people believe that once you failed a meaningful use audit a few years ago, you were automatically scheduled for an audit for a different payment year. Now, we can't prove this, and CMS has not specifically said anything about this, but it does make sense. These audits are in place to ensure incentive monies going to individuals who are actually meeting the program. So if you attested you were and then you failed, why wouldn't CMS flag your name and come back and check up on you in subsequent years? And then finally, one that is probably most surprising and unnerving is the failure of an audit by colleagues. More and more, we're seeing one provider of a practice being audited who then fails. And it just happens, that in the next few years, in that very same practice, another provider is being audited. And you have to think, in CMS's eyes, this is going to make a lot of sense. If all the providers in one practice have similar workflows, similar care methods, similar policies and procedures in place, it's a good indicator that more than one provider may not be in compliance. So keep that in mind as well. So how do you know if you were selected for a DVA back in 2019? Well, I hope it hasn't taken you 2 years to figure this out. But also for those of you who, could be selected in the future, the process is going to be very similar. So if you're selected for a data validation audit, you're going to receive a request for information from Guidehouse directly. They said it can be sent via email or certified mail. I would say most of the requests went by email. And CMS has said they would send those out in June or July of each year. And that email subject line will say notification of data validation performance year XXXX, whatever year they're coming after you for. From the date that you got that email, you will have 45 calendar days to provide that requested information. And per CMS, if you don't provide that requested information, CMS may take further action. And again, they even said, include the possibility that you'll be selected for future audits. Now, that 45 calendar days can be scary to some, and notice it's not business days, it's calendar days. We have seen CMS agree upon an alternate time frame, but very, very few instances. So I would be prepared for a 45-day deadline. Now, something to note that is different from the previous meaningful use audits is that these DVAs are done by category. So MIPS has 4 categories, right? Quality, promoting interoperability, costs, and improvement activities. While the number of measures or activities that are selected for DVA from each category are actually going to mirror the weighting for scoring. So what that means, for performance year 2017, approximately 60% of the total audits in a submission category are going to be for quality measures. 15% of those will be for improvement activities, and 25% of audits will be for promoting interoperability. Same thing with performance year 2018. You can see, and I'm sure we remember, the weights changed a little bit. Cost had increased and quality went down by 10%. So we can see same thing for audits, only 50% of the audits will be for quality instead of 60%. CMS has stated they are not going to conduct any data validation or audits on the cost category. I think that goes without saying. Obviously, we don't submit any data for costs. CMS gathers that from you, from your claims already, so they already have that. So you can see improvement activities have the lowest chance for an audit, then PI, and then quality. Again, this is going to change as quality becomes a lower weight over time. It'll eventually even out to almost every category being pretty equal chances of an audit. But Pay attention which category you're selected for, and you could be selected for quality in 2017 and maybe improvement activities in 2018. There's no rules against that. And again, I think this goes without saying, with all the hardships that we've had over the past few years, you're only ever going to get audited for the data you submitted. So if you took a hardship for COVID-19 and you didn't submit any data, there's no chance you'd be audited for that year. Same thing, if you only submitted on 2 categories that year and used the hardship for the other 2, you're only ever going to be audited on the data that you actually submitted to CMS. Now, to make life easier, CMS did finally come out with a MIPS data validation zip file, and it's available each year. So the audit requirements are maintained for each performance category, and they actually provide guidance to auditors that are now available to you as well. So to access them, you would just follow these steps on the QPP website. You just want to go to the resource library and you can search data validation, it'll come right up. And it can absolutely be helpful to review these requirements as you build your binder, so you know exactly what an auditor expects. It's no secret. I personally find the improvement activity one to be the most helpful, as most of those activities are left pretty broad, and the validation documentation section will give you ideas or examples of exactly what they would want to see. And you can see here, let me pull this up, I had some animations. You can see here the PI file and then the improvement activity examples. So if you look at the improvement activity, here's this 24/7 access. And you can specifically see what the auditor would want. So under that validation documentation, they're looking for a patient record from the EHR with a date and timestamp indicating services provided outside of your normal business hours. You can also show them a medical record or a claim, and you can also show them a same or next day patient encounter within that medical record, indicating that that patient was actually seen that same day or next day. As you can see, that same or next day appointment's not something I would have immediately thought of for proof of this. So I highly recommend reviewing this document for whatever activity you choose. Okay, so moving on to the actual category documentation. Again, that was our brief, a little bit longer than I thought, but overview of the audit process and what's currently happening. But let's look at what you should actually have in your binder for each year. And please note when I say binder, it could actually be a physical paper binder, but you can also create a secure folder on your computer as well. Just make sure to have it backed up. Old habits die hard, right? I just always say binder. So let's start with the promoting interoperability category because this category has the most audit documentation associated with it. So to recap, under PI, you have measures with data. Think numerator and denominator metrics that you track throughout the year, likely using the HQM. So these are going to be things like the e-prescribing measure, your HIE send and HIE receive, as well as your patient portal access. But you also have attestation measures under PI that you simply attest yes to, but then you have to have that documentation to support that yes. So those are things like your security risk analysis, your prescription drug monitoring program, as well as public health reporting. There's also documentation to prove that you are actually using 2015 certified EHR technology or CERT functionality, as well as other reports and things that support metrics like the e-prescribing measure to prove certain functionality for things like DUR checks or formulary updates were in place. And we'll go over all of this with screenshots. So to start, the easiest are the measures with data. They're easy because you just need to export your HQM summary report or practice report, depending on how you're reporting, group or individual. But here are some things to keep in mind. You want to export the report when you submit. So your numbers match exactly what you submitted to CMS on your exported report. If you download them too early, there actually may be very slight changes in percentage or data, just as encounters are closing and locking after the year ends. Also, some of the PI measures have exclusions. For instance, if you prescribe less than 100 prescriptions, you don't need to report on that ERX measure, and you can claim an exclusion. But if you claim an exclusion, you would want to run your PI report showing the denominator was under 100 before you remove it from your HQM configurations, so you have proof that it was under 100 and you were allowed to claim that exclusion. The same idea goes for the HIE send or HIE receive. Next, you want to download your cert ID, which if you're submitting via HQM, you have to actually input in order to unlock the submission file anyway. So to get this, you would just need to go to the Chapel website and search for NextGen. You would then find the version or versions you were on during your 90 days. This is likely only one, but if you did perform an upgrade mid-reporting period, you may have to select two. You would then hit the plus cert ID button, and I can pull up a screenshot here for you. And that essentially is going to add it to your cart, like you would be an online order. And if there's only one, if you don't need to add two different versions, you would then hit the yellow Get 2015 EHR Certification ID, which you can see in the second screenshot. This is going to give you a special ID, and it's going to allow you to save it and export it as a PDF, and then add it to your audit binder. Along those same lines, your next document is a report showing your system's upgrade history. So this is documentation of when your cert was actually installed. You have two options. You can either run a Crystal report or a SQL query. For the report option, in the EHR, when you go to Crystal Reports, the report dialog box will appear, and you'll want to click on All Encounters for All Patient to expand the section. You would then choose the MU Audit Report and click Preview. You would, of course, enter in the parameter value window, choose the drop down, EHR upgrade history in this case, and then you would select OK. Now, fun fact, there are some Crystal report packages that you have to download if you don't see this report. So if you don't see this option in your system, which to be fair, when we went in our test system to do this, we didn't see this option. So if that happens, you should go on the Success community to get the MU audit data zip file to then download and access the report file and install instructions. It's very straightforward. We actually, like I said, didn't have it in our test system, and Lexi was able to do this for me in about 3 minutes. And I do actually have a link to the Success community where this audit Crystal report is downloadable. If you do need that, it's just a few slides ahead. Now you do also have an option to run the SQL query. We included that on here. It is a screenshot, so you won't be able to copy and paste. I apologize. But again, you have it right there. You would just need to type it in on your own. Now, along with this information, you're also going to want to note the latest patch that you're on. There's no compliance patch this year, like there has been in the past, but it's still important information. So there you'd want to go to System Admin, Help, and then About Security Administrator to get this information, which is the last screenshot you're seeing. NextGen also recommends to make a copy of your NextGen healthcare license agreement and any invoices from your original purchase. Again, that's more of a one-time thing. If you already have this set aside in your binder or saved out somewhere from previous years, that's something you can just pull forward each year. Now, the next report we want may seem a bit odd, and I'm not positive this will carry into the MIPS audits, but it was required for the meaningful use audits, and that's the patient seen using the EHR report. So we would actually help clients meet this by running an appointment log report in PM to show appointments that took place during the reporting period. And then, also provide a list of patient encounters from your EHR system to cross-check the appointment log. Now, the procedure EHR report will likely have to be set up or configured to run. So for instance, where you're seeing that long list in the center here of office emergency care, office outpatient visit new, that was blank in our test system. So you're actually going to probably do the same thing we had to, where you would add the procedure codes you want to include on that report. And to do that, you would just click on the ellipses, which we outlined here, and you would search by either the code or the description you want to be included. And you might be asking, well, what do we include? We always say the procedure codes that you typically bill for. I would also include a list of providers who are active at your practice that year and reconcile it with the CMS list. That would be in your QPP portal. That CMS website will show you your clinician list for each year as well to have on file. Now, next up is documentation associated with a data PI measure, the patient access measure, or that portal measure. It does require you to provide patients with access to their health information using an application of their choice. This may be, an iPhone or an Android app or any other kind of technology the patient wants that's capable of configuring to the API specifications. So NextGen Patient Access API is that certified solution for giving your patients that secure access and meeting this requirement. So to prove that you had this API installed for the entire reporting period, you can check in two places. Easiest is probably going to be in the HQM under the config tab and then going to the practice page. Or you can log into the API Suite Manager, which we provided a link to a step-by-step guide on how to check if and when the API was installed. So two options here as well. Our next measure is the ERX measure. This one specifically requires a few different documents besides just your HQM report. So again, here's where that Crystal report package really comes in handy. This is where I have it linked if you do need to download it. You do need to provide documentation that your formulary was available for the entire reporting period, which you can do by running both the formulary patient eligibility and the formulary update history reports from this package. Along with those formulary updates, you need to provide evidence of DUR checks, which are the drug-to-drug and drug-to-allergy interaction checks. Again, this needs to be enabled for the entire reporting period. So to prove this, you would run that Crystal report for the DUR checks by provider. You also need a screenshot of the system admin to show your interaction checks are all above the minimum level display of 0. So to do this, you would actually go into System Admin, View, then Universal Preferences, and then the Medication tab. And you would look for those highlighted red portions that I have in the screenshot here. Again, we want a display level minimum of greater than 0 because that means the providers can't turn it off in their user preferences. That's what that's telling us there. But you aren't done there. You also need a screenshot of your attestation information pop up, which shows again that DUR alerts were enabled. So this is only going to be viewable when a provider logs into the EHR, or if you as a user is linked to a provider in System Admin. And again, in the EHR, you would go to View and then Attestation. And if you can believe it, we're still not done with the ERX measure. The last piece of documentation you would want to have on file is if you participate with a prescription drug monitoring program, so PDMP or a PMP. So this can either be through your EHR or outside of your EHR through maybe your state PDMP or PMP program. This measure is strictly for bonus points. It's not required, but it is worth 10 bonus points this year, which is a huge help in this category. Also, you can see I included a screenshot of a case that I had open with CMS. They confirmed as long as you have one provider check the PDMP one time during the reporting period, you can claim this. Especially think for group reporting, just one provider one time counts for the whole group. Now, this is different than the improvement activity requirement. Since you have to be for an improvement activity to claim credit for this, you would have to have 50% of providers doing this for over 75% of instances where this is required. So be aware of that difference. But if you would like to claim this, you just need a printout from the PDM portal that proves you're registered and shows an example of this being used during your 90-day period. Most PDMP portals I've seen by state are pretty easy to navigate and get this exported. Now onto a true self-attestation measure, the public health reporting or the clinical data registry reporting measure. This measure requires a provider to be in what they call active engagement with 2 of these or to be able to claim an exclusion. So to be considered an active engagement, you have to provide the name of the registry and dated confirmation of at least one of the following. So either proof of registration to submit data within 60 days of the start of the EHR reporting period, or confirmation from the registry that you're in the process of testing or validation before actually sending the data, or confirmation that you are in fact sending that data to the registry already. Examples of this would include emails from your registry, screenshots of some sort, even a letter like the one shown on the screen. Most registries are very familiar with this requirement. It was from the old Meaningful Use program as well. It's not new by any means, and they should be able to provide evidence for you if you reach out to them. Like again, one of my clients reached out to theirs each year, and they received this letter. Now, on the flip side, let's say you only have one registry and you would like to claim an exclusion for your second. You have to supply supporting documentation of, again, meeting the measure or meeting the exclusion. So again, this is going to be things like a dated communication or screenshot from your specialty society website that they don't know of any registries for the specialty. Dated communication or a screenshot from a registry saying they're not ready to accept your data yet. Data communication that your state does not offer a specialty registry, which is a great example of what you're seeing on the screen. This is from a state, Indiana State Department of Health, saying that they cannot accept data from providers specifically right now, and they offer a link to the exclusion letter to put in your binder. Or for instance, proof, I know a lot of ophthalmology providers or specifically, but any provider who doesn't administer immunizations, this is claimed a lot. Proof for this could be as simple as a statement with your practice letterhead on it saying this provider does not give immunizations with it signed and dated. And last but not least for the PI category, finally, is our crown jewel, the security risk analysis. So the SRA and I have a true love-hate relationship. If you can imagine a nuclear bomb went off on Earth and something survived, it would be the security risk analysis. I only mean to say this thing is never going away. And no matter how many program overhauls, MIPS or meaningful use or the MIPS value pathways goes through, this thing will survive it all. And ironically enough, this is actually the most frequent cause of providers to fail an audit, more than any other requirement. So providers need to conduct a security risk analysis and update it annually based on changes made throughout the year. Within your security risk analysis, you want to make sure that you have a remediation plan in place for any risks that you identified by a certain date in which you plan to remediate each risk. It should cover a span of the entire year. It's not episodic. Now, the ONC as well as the OCR came together and actually developed a downloadable SRA tool to help guide you through this process. So this tool has actually helped to design and help you and your practice conduct an SRA that's required by both HIPAA and CMS and be in compliance. Now, all that information entered into that SRA tool is stored locally to your computer or tablet. HHS isn't receiving any information or collecting or reviewing it for you. And then the results of the assessment are actually displayed in a report, which can be used to determine certain risk policies, processes, actions you need to take from it. So this is the link that you see on your screen. So if you don't have an outside vendor doing this for you and you've not done this yet, this link may very well be your new best friend, and it will likely start your own love-hate relationship with the SRA requirement as well. Now, a few myths surrounding the SRA that I do want to dispel immediately. Again, it's the measure that's been around forever. It's like an extremely old house that has ghost stories surrounding it and no one actually knows the truth. So some of the most common things I hear are, I have to outsource the security risk analysis. That's false. You do not have to. You can, and it does make life a lot easier. I'll give you that. But it is possible for your practice to do a risk analysis yourself. Again, and that tool that we just shared on the previous slide could absolutely help you with that. A checklist will suffice for the risk analysis. False. Checklists can definitely be useful tools, especially when you're starting a risk analysis, but they fall very short of performing a systematic security risk analysis or documenting that one's been performed. So a checklist or a one-page document is not going to suffice. Next one, there is a specific risk analysis method that I must follow. False. A risk analysis can be performed in countless ways. Again, we do have guidance out there from that link. OCR also, the Office of Civil Rights also issued guidance on their recommendations, but this is just guidance to assist you. It's not any sort of requirements. Next one, I only have to do an SRA one time. Again, false. To comply with HIPAA and MIPS, you have to continue to review, correct, or modify and update those security protections and risks. Again, you don't need to recreate the wheel each year. which is our next one here. I'm giving it away. Each year I'll have to completely redo my security risk analysis. That's false. You can perform the full security risk analysis as you adopt an EHR, and then each year when your practice changes or updates happen, you just have to go back and make sure that it's reviewed and updated. Now, this does not have to happen within those 90-day reporting periods of your PI category. You just want to make sure this is completed within the same calendar year. So again, make sure you have this completed or updated for this year. You've only got, a few weeks left here to make that happen if you need to. So on to our next hardest documentation category, improvement activities. As a recap, to get full credit in this category, you're going to have to report on 2 high-weighted activities or a mixture of medium and high-weighted activities. Unless you're a small practice, if you're under 15 clinicians, you only actually have to do half of that. So maybe 1 high-weighted or 2 medium-weighted. Now, for this category in particular, it's hard to give examples like PI because everyone's going to be different. My recommendations are to immediately download the data validation file for improvement activities, select activities that your practice is already doing and doing well, and then follow the suggested documentation for the activity in that file to dictate what you save down. So again, some examples that we've seen clients save down are screenshots of functionality, some HQM reports, policies and procedures that you have in place, AUC examples, portal documentation, maybe meeting minutes or training materials, or any type of agreements as well. So if we look at the activity I pulled on the screen that I think would probably apply to most practices on the call is engagement of patients through implementation of improvements in the patient portal. The validation documentation that CMS is suggesting is screenshots of the portal. Typically, we do screenshots of functionality from the patient portal, the patient perspective of the patient portal. So how they can access education. We also try to find portal messages from patients that the practice responded to show that bi-directional communication. And then we also use the PI report from the HQM to show how many patients have access to the portal. So likely for an activity, you'll have a bunch of different examples, or you should try to back that up. Again, this is just an idea of what we try to put in place based off CMS's advice, but this is what an auditor is going to look at as well. So please don't ignore this file. Something else to note that's brand new in 2020 due to the final rule that was released. NextGen HQM as a qualified registry is required by CMS to actually validate your documentation for improvement activities. So this isn't technically a new requirement since you should always have documentation to support your improvement activities. However, last year was the first year you actually had to submit that evidence in order to be able to submit via the HQM. Now, if you choose not to submit in the HQM and you want to do this manually via the QPP website, you can, and you're not required to upload the documentation. But keep in mind, CMS knows NextGen requires this, and they do. So we have a feeling the odds of you getting selected for an audit are likely a lot less because you had to go through this process. Now, once your documentation has been approved, which if you're wondering what they're looking for, refer to that CMS validation spreadsheet. NextGen's following that exact same thing when it comes to approval. Also, we have the ability to auto-validate certain improvement activities. So here's an example. This is from last year. I don't know if this has been updated for this year. Some of these activities you're going to get auto credit for if you have this. A great example is the depression screening. If you have the CMS, the ECQM measure 2 depression screening added to your HQM report and you have data in that measure, they can give you automatic credit for this, and that will serve as your documentation. Now, just because this has been auto-approved doesn't mean you shouldn't run the HQM report for your improvement activity reporting period and save it down. So this is going to mean likely reconfiguring your reports, for instance, running that ECQM report for depression screening for 90 days versus a full year, so you have set proof of this. So our last category is quality. I only have one slide on this because this is probably the easiest one to prepare for, which is great considering this accounts for most of the audits for 2017 to 2021. Essentially, you need your certified reports from the HQM that match exactly what you submitted. I would also run the practice patient report for all patient statuses, so you have encounter level data on each of those measures as well. So that report's going to give you the encounter and person numbers for each measure for who exactly is included in your numerators, in your denominators, who failed to measure, who was excluded. This way, if CMS audits you and they want to see examples of an encounter where you're meeting this, you already have your list ready. So it basically gives meaning to your certified report that just has percentages on it. You can also download the white papers for your measures off the Success community, not only for workflow purposes, but if you need to show the auditor what the workflow was, but also for mapping purposes. I have had an auditor ask for the report logic in an audit. So they may dig deeper and ask, how does the HQM track or map a certain measure? You never know. So that will also have the specifications in there as well. All right, so that was a lot of information and examples of what to include for each category, but there are still just a few more items I would include in your binder that aren't category specific and focus on proof of submission and scoring. So the first items would be screenshots from the MIPS dashboard and the HQM. So the MIPS dashboard has been around for a few years now, but it allows providers to actually monitor their performance for improvement activities, PI, and quality. So the dashboard is going to display provider performance data at either the individual or the TIN or the group level for generated submission files. So you have to have a submission file generated for this to read it. The performance scores are based on data calculations that are actually returned directly from CMS's QPP submission API. So you can actually see a preview of your scores prior to submission and your scores after submission for each category. So to do this, you would go to the HQM homepage, you would select reports at the top, and then the MIPS dashboard is the last option to use and view this tool. Now, when you are viewing this, you can see there's actually two types of scores, either a preview score or a submitted score. The preview score is going to enable you to see your initial MIPS performance category scoring. The HQM portal does this again by periodically sending that to the API. The submission score that you would see here would be available after you submit your data. And that's based on when it returns. So you also might see a few additional bonus points come through that CMS added for complex patient bonus, things like that, that you wouldn't see in your preview score. What few people don't know about is that you can actually, within the dashboard, click your total score to see more details about your category scores. So again, you can look at the raw data portion of it, which has been available for a few years, but it was hard to read and not very user-friendly. But they did add, as of last year, this new visual representation as well. And this is going to show you, the exact scoring for each measure. And it's, again, extremely helpful. Particularly for the quality category, because typically when you're looking at benchmarks, their whole numbers, this will actually add the points, of making that 10.94 and not just a 10. So again, I would take screenshots of this to have in your audit binder as well. And then here's the raw data view that, again, like I said, just wasn't as user-friendly, but still good to have as well. And last but not least is your submission ID. I've always had clients ask me, how will I know when it's submitted and accepted by CMS? So, on the old CMS portal, you used to get a notification saying it's been accepted. You would take a screenshot of that and you would keep it in your audit binder. Now in the HQM, if you go to the program submission page and click view file, you should see file names and statuses. Files that are approved are going to be green, like you can see at the top, and files that have actually been submitted will be blue. So what this looks like, CMS actually returns what they call the CMS batch ID. And this is what I would screenshot as proof of submission. It's like having an order number, right? If you had an issue with an online order, you would need your order number to call, and if anything was wrong. Same thing here. And again, this functionality is the same for PI, quality, and improvement activity. So I would take all three screenshots. And typically, just so you know, because I know we're getting close to submission time, it only takes about 2 to 5 minutes for that status to change from approved, that green, to blue of submitted. So you should be able to get that screenshot fairly quickly right after you submit. Okay, well, I'm going to turn it over to Holland very quickly for a brief overview of some other overall documentation recommendations, and then we'll come back for that one slide overview for 2022, and we'll be on for questions. So Holland, it is all yours.
Thank you so much, Lindsay. Okay, so let's take a look at some overall documentation recommendations we have for an audit that we haven't explicitly touched on. So some of this you may feel like we have already mentioned, but we just want to make sure we have clearly stated some of the most important recommendations on documentation. So here they are. First things first, you need to create that audit file for each MIPS performance year. So this file can include copies of any email correspondence you may have had with the QPP Service Center, documentation supporting and justifying a decision to apply for a PI hardship exception, screenshots that include the practice's MIPS participation status on the QPP website. So if a practice or clinician is listed as not being eligible for the MIPS on this website, but the auditors don't agree, a screenshot will afford some level of protection there. And lastly, results from internal MIPS audits conducted by the practice. Internal MIPS audits should review documentation, actions, and reported results for each MIPS-related activity. This is not an exhaustive list. There are multiple other things that we do recommend including. Those can range from submitted quality measures, submitted improvement activity measures, submitted PI measures, even including practice and provider information for that year, which could be, business name, address, tax ID number, provider names and NPIs, things like that. Truly, your audit file can never have too much information. So to that note, here is a quick audit checklist for you to have on hand, specific to the HQM and some non-HQM items that you'll want to keep in mind. Again, this is not an exhaustive list, and there are more things that you could add to a binder, but these are some of the most common that would apply to everyone. So on the HQM side, summary report or practice summary report, provider patient report, reports back up to the IAs, reports to backup exclusions, screenshots of CMS batch ID for all submission files, visual data, screenshots from your MIPS dashboard, and then also on the non-HQM side, proof of API installation, cert ID or latest patch, upgrade history, formulary and DUR checks, things like that, just to keep in your checklist. So now that we've outlined what to include in that audit file for each MIPS performance year, you do want to make sure that you keep that documentation for up to 6 years in order to be in accordance with the False Claims Act. So the 6-year timeframe allows CMS the ability to request any records or data retained for MIPS purposes within that window. This was finalized in the calendar year 2019 QPP final rule and is for all MIPS performance categories, excluding cost, considering that no data is submitted for the MIPS cost category. It is crucial when retaining that necessary documentation for your audit preparedness that you keep in mind and respect the HIPAA minimum necessary standard. So being sure to redact or blur any PHI if or rather when the auditor requests specific records. So if that piece of information is not required to fulfill the purpose, keep it out. It's also important to know that any documentation to the auditor needs to be sent back through the Guidehouse HIPAA Secure File Sharing Platform or SecureFax. So on the theme of recommendations, we're suggesting you create a checklist of all required documentation, print the documentation and put it in a binder or save it electronically. Make sure documentation in form of screenshots include date and times. Keep the documentation separated from year to year. So keeping in mind as well that it needs to be kept for at least 6 years. Making sure that you're identifying a safe place for your documentation. So if it's in an office, is it safe from a fire? Is it safe from a flood? If it's on a computer, is it backed up in the event of it being destroyed or stolen? Make sure you have policies in place to transition the documentation if an employee would leave the practice or organization, keeping in mind working with and communicating with the auditors. In the event that you can't meet a deadline, make sure you let the auditor know as soon as possible. If you have any questions about the information being requested, ask the auditors for clarification. Also, and lastly, to conduct a self-audit. So internal self-audits measure your EPs attested to help ensure a positive outcome to a CMS-initiated audit. So it's going to help you understand what documentation is required to support attestation and identify any potential gaps in documentation that you can address with your EHR vendor. And lastly, iTentiv's trusted advice. You can never be too cautious, and you can never have too much documentation. Your binder should be ready to go before you even consider attesting, and it cannot be an afterthought. Also, really importantly, remembering that audits are a team effort and not one single person's responsibility. And more specifically, to bring back the most cliche audit quote that you have probably heard multiple times before, by failing to prepare, you are preparing to fail. But it's true, and it says a lot in a few words. You need to prepare for an audit now and not when you're in the middle of one. Just think 6 years from now, things could look very different in your practice, and you don't want to have to try and dig backwards to not fail. You want to be able to open a file or grab a binder with everything you need and not have to panic. So with that being said, I am going to go ahead and pass this back to Lindsay, and she can go over very briefly those 2022 changes we might be seeing.
Great. So thank you, Holland. As I said, time permitting, I would cover these changes for 2022 in the fastest, most brief way I think you've ever seen in one slide. So obviously, this list is not exhaustive. There are more changes, but these are the big ones that will likely impact you all on the call for your reporting next year. These are the things that I think you need to know 100% before January 1st hits. So first and foremost, CMS did add 2 new clinician types to be eligible under MIPS, the clinical social workers and certified nurse midwives. So if you have either of these clinician types, previously they were not included under MIPS, you will now need to officially add them or activate them likely in the HQM and add measures for them. Second, quality and cost weights changed this year. Quality actually decreased and cost increased, and they are actually the same. They are both weighted at 30% of your score. The thresholds changed this year. So the threshold to avoid a penalty went up by 15 points. It's now 75 points to even avoid a penalty in the program. It was 60. And the exceptional performance threshold, that's that threshold. Again, it's only for 5 years. Next year is actually the last year for this. Only went up by 4 points this year. So if you score above an 89 composite score, you're part of that exceptional performer category. Now, quality specific changes, again, I literally just included 3 of them. Quality first, there will be no more bonus points offered for submitting additional outcome or high priority measures or end-to-end bonus measures. For PI, there is now mandatory reporting on immunization and electronic case reporting instead of those public health or clinical data registries. If you have an additional one, for instance, that you had for your specialty, those will be worth 5 points. No matter how many you have, if you have 1 or 3, you're just going to get 5 points. And then another one for PI, there's a new measure that they added. It's called the Safer Guide Annual Assessment Measure. Sounds very similar to a security risk analysis. I would assume that it's just on a smaller scale. They do have information and guidance out there for this, but this would likely be a similar resource to performing your security risk analysis. And if I had to pick just one of these changes that I think will have the most significant impact, it would be the no bonus points in quality. I think this will be incredibly more difficult to even score over 40 points now in this category. It's likely going to really lower scores compared to what we see now. All of you who submit through the HQM currently, just immediately chop off 6 points out of your quality score. And then again, I'm sure most of you, if not all of you, depend on a few extra measures in there for bonus points that are high priority or outcome to add to your score. So that's a total of 12 points that could be taken away from your quality score of what you're earning right now. But that is enough on this. It's an audit webinar. I couldn't resist. So, moving forward and looking at what our next steps are here. Go ahead and visit our website. We have attentive.com, but we also have, as Chelsea mentioned in the beginning, see what new things we do have to offer now with DAS Health at DAS's website. Continue to sign up for these webinars. Like I said, reach out if you ever have any webinar topics or suggestions. DAS will also host webinars. They do one specifically on MIPS as well. It's just not EHR specific, so it'd be much more interested or much more focused on the total program itself and the requirements. If you do need any assistance, whether it be for this year still with help reporting or submitting, or to get set up for next year, we do still offer our 3-tiered fixed price macro support packages. I know a lot of you on the call I'm already working with, but this is a great option, specifically the fundamentals package, especially if you're looking for any type of assistance this year even, it's not too late. And then as we talked about the security risk analysis with DAS now, they actually offer a complete security risk analysis solution. So if you are looking for some assistance to that, I did actually put the link to their page for this. They have different levels based on your practice size, so you might have to navigate that, but that link should get you started. Okay, finally, questions. Again, we have our contact information up on the screen if you have to jump off and you want to email us a question, or again, if you'd like to learn more about us or get some additional help. I'm going to turn it over to Chelsea to read out loud any questions that were put in the chat. But again, before I do, I just wanted to say thank you all for staying on this whole time. I know it's been a long one.
Okay, thank you, Lindsay. Thank you, Helen. And again, thank you everybody for joining us today. As Lindsay said, we're going to go through the questions in the order that we received them, which normally might be noteworthy, except for the first time ever, I've got to say we only have one question. So I don't know whether Lindsay's put you to sleep or if she answered your questions so thoroughly that you have none.
Let's
Either
go with
way.
option 2. Let's.
If you have them, feel free to type them in. We got plenty of time to answer them. And so let's start with the one that we have. For group reporting, do we need to keep records for all providers individually, such as final PI HQM reports?
Perfect. So that's a great question. If you're reporting as a group at the tax ID level, the reports you're using the HQM should be the group ones. They're the ones that start with practice. So practice summary report or practice patient report. So those are going to be your certified reports, and that is not at the individual clinician level. That's at the tax ID level. If you're referring to other supporting documentation for maybe measure specific things, you can run a group level report for individual providers. You would just use the practice patient report, and then you would select individual providers for that. That is good to have for certain measures. In particular, I think of an improvement activity, for instance. If you're trying to prove that 50% of your providers do the PDMP measure, for instance, you would run that PI report at the group level, but by individual providers. So I'm not going to say a blanket no, you wouldn't need those because there are some other scenarios that you would. Again, you could never have too much documentation. So if you can run those reports and you have a resource who knows how to do that, I would add them to your binder, yes.
Okay, well, no more questions have come in. We can hang on. Oh, wait, we got one. Will we get an email of the slides or the recorded meeting? Yes, you'll get both. So I'll be sending out a link to the recording along with a copy of the slides within the next few days, possibly maybe even early next week. I've got to get everything uploaded, but we will send those out whether or not you were able to attend or not to everybody who registered for it. And if you have questions after reviewing those, or if you share them with coworkers, and if you have questions then, feel free to always reply back to that email, or again, any way you can get a hold of us, we're happy to help. So thank you for joining us, and we look forward to seeing you in the new year. I hope that everybody's holidays are great, and we look forward to, maybe next time reaching out to you under our new brand of DAS Health. So keep your eyes out for that too. Thank you, everyone.
Thank you.
Thank you.